to our channel, Dr. Shreyas. First of all, thank you so much for taking your time out and coming and joining us. Moving into neonatology, how much do you enjoy this space? Do you?
Definitely.
Okay.
It's actually, as a pediatrician, everybody would be already, whenever we do a PG in pediatrics, we do have a certain amount of time we spend in neonatology also. We have a separate paper for neonatology, we do write, we learn it in our post-graduation itself, neonatology and pediatrics. So basically, if you ask me whether you are specialized in neonatology, for every pediatrician is specialized in neonatology,
Okay.
I would tell. So as separately as a neonatologist or doing, there is a separate course for DM neonatology which is for another 3 years, or there are fellowships in neonatology which is either for 1 year or 2 years. They get what specialization in neonatology is extra things, you know how to care for a preterm child, or you can see separately how to put procedures to be done to a neonate, or how to look after specifically for those like disorders which is specifically in the neonatal period. So you get specialized in treating them, that's all.
Okay.
So yeah.
For the audience, what is neonatology?
Neonatology is treating the children who are born to 28 days of life. That is
Born
1 month.
to 20. Okay.
That is 1 month
1
of
month
life.
of 1 month of age.
Yes.
What is preterm?
Preterm is below gestational age, we call. So 37 weeks and above, we call a full term baby. So any baby who is born less than 37 weeks, we call them preterm.
Okay.
Okay. Then from 37 to 40, we call them term. Post term, we call after 40 weeks of duration.
Okay. Okay.
So why that post term is also important is mainly you can see the doctor would tell you the baby has already passed stools in the stomach, will have to emergency do cesarean and everything. That is more common in postpartum babies. So if the babies have passed the stools or ingested stools into the lungs, they will get again the respiratory problems and everything. They'll have to be in NICU. So those things are more common in the postpartum babies. Term babies, there are few conditions. What we call as, what we mainly are seeing now because of the cesarean section is transient tachypnea of newborn, we call it. For a transient period of time, the baby will have respiratory distress.
Okay.
It is because there is a certain amount of fluid which is present in the lungs when the baby is inside the mother's womb. So in a normal delivery, it can happen in normal delivery also, very rarely. But what happens in a normal delivery is whenever the baby is coming out, it squeezes and comes out of your birth canal. So the lungs get squeezed, and when the baby cries out, the all whatever is there, the fluid
Goes inside.
Yeah, comes outside of the lungs.
Okay. Okay.
So that there is space for breathing. Air is there. Okay. That time there is no much of distress. If there is no absorption, LSES or cesarean is we passively removing the baby from the mother's womb. The baby is not coming out on its own. So there are chances of that lung fluid which is remaining in. Okay, or we call it as delayed transition to the neonatal life. So the fluid is not coming out of the lungs, so they have breathing problem during that time. Normally it does settle by 6 to 8 hours of life, only in 6 to 8 hours, but we'll have to give again, oxygen has to be given. What we give normally as CPAP, with pressure, we give oxygen to the baby to help to open up the lungs and to remove the fluid out of the lungs. So these are some of the problems are there in the term babies. Again, there's a whole lot of problems which are there in the preterm babies. Why? Because preterm babies are born early, their organs are not developed, starting from your lungs to your intestine. So directly your lungs are not developed, they will have respiratory problem. So very preterm babies who are born very early, like nowadays we have seen more than 24 to 26 weeks babies are surviving. First they used to tell below 27 weeks is not viable. Means baby can't be survived below 27 weeks. Now the medicine field has developed so much that 24 weeks onwards babies are surviving in NICU.
Nice.
So the first and foremost thing is giving surfactant. Surfactant is medicine. Actually, it is produced in the lungs of the normal babies. Okay, that helps to reduce the surface tension in the lungs and then helps for the breathing and everything. So preterm babies, it is not developed. So what we have to give an exogenous surfactant from outside. We'll have to intubate the babies and give it directly to the lungs. That again costs around 11K to 12K for a small bottle of surfactant. That has to be given to the babies if they are born preterm. Okay, just because their lungs are not developed. Then later when you start feeding, their intestine is not developed. So when you start feeding the child, even we give as minimal enteral nutrition. Start with 1 ml. When mother gives milk, we start with 1 ml. So there are chances of feed intolerance. Baby may not tolerate even 1 ml feeds. So whatever everything may come out. And whatever we have given also may not get digested. So sometimes we call very preterm babies, we call it as necrotizing enterocolitis. Means the whole intestine can get necrosed.
What does that mean?
It's basically due to sepsis or infection.
Okay.
The whatever feed we give is not getting digested. The intestine has an infection. The baby's intestine has small intestine has infection, which is again causing sepsis or infection to the child.
That's
the child is not
fatal?
able.
That is very dangerous, right? For the child?
There are again grade
Infection.
1, grade 2, grade 3.
Okay, never mind.
Grade 1 is very, it can be, we do normally stop the feeding for 3 days, give antibiotics and stop. Grade 2, we stop the feeding for 7 days, we give antibiotics. And then grade 3 can easily go up to surgical procedures. We'll have to glau drain or resect the necrotized intestine bowel and then attach it back.
Okay.
So it's again goes to
Complex.
very surgical problems. So preterm has a very the complications are very huge in preterm. So getting out of that preterm phase is a very challenging task for a neonatologist and for the mothers and for the baby.
It's very difficult for the moms also, right? How do you handle that?
Uh,
I mean, I'm sure they are just waiting outside the NICU all the time.
Yeah.
So,
The one more thing which has come up is family-centered care in
Okay.
NICU. This family-centered care means you have parents are allowed inside NICU. Okay. There are other NICUs where parents are not allowed. Only the babies are there inside. Doctors are taking care. Nurses are taking care. This family-centered care NICU is where you allow the mothers and the father. Basically, we allow only parents. So they do come to NICU. They do see their child day in and day out. So it is like at least by the look, by the sight of the child, they have that bonding. Okay. Then once the child is okay, at least taking full feeds of the respiratory care and everything, we do the congru mother care. We give the inside NICU, we tell the mother to come sit, hold the baby, give feel the warmth, give the congru mother care and everything, so that there is bonding which is developed between the child and the mother even when the child is in NICU.
okay.
So
What
this is
are,
coming up everywhere.
Okay. What are some of the issues that happen in terms of mother and child related, not just bonding, it could be feeding and it could be patterns of life, like sleep patterns, whatever, however you're bringing up that child. What are those things that come up because of a preterm baby? Like feeding is an issue. What other things are there like that?
One, everybody has the concern whether the child's developmental. Again, a preterm will have, what we do is a corrected gestational age. Okay, so every preterm child will have a little delay because it is born early.
Earlier.
That delay will be there in the development. That is one of the concern which the mothers will have. The other thing will be feeding again issues. Feeding issues will be there. They will be because of the low weight, they'll have to feed, extra feed may be required. mother's feed plus the formula feed may be required for the babies to be given. And then repeated infections is the one the preterm child can have. Okay.
Are they low on immunity?
They are more prone for infection, you can tell, because of the less immunity is one thing maybe. And nowadays for the repeated infections, because the preterm child, they would have gone through intubation and everything in their NICU course, and been repeated infections may be there, you would have given antibiotics and everything. So there are high chances for a preterm child, it's always the high risk of getting more infections than you do for a term child, term babies.
What has been the earliest, what is the right word? The most preterm, what is the correct word for it?
Yeah, the early preterm or the very preterm.
How early a preterm have you actually encountered and survived? The baby survived.
After coming to Bangalore, maybe 26 weeks.
Okay.
26 weeks. We had a baby when the time I came to Bangalore, maybe like 8-9 months back when I came to Bangalore, we had a baby in our hospital who was 26 weeks, was running, which was 580, I think 580, 600 gram baby it was.
Oh my God.
Okay, when we discharged the baby after 1.5 to 2 months, that baby stayed in NICU for 1.5 to 2 months, had various problems again, respiratory issues, infections and everything. It went through so much, and then while getting discharged, I think it was 1.8 to 2 kgs while getting discharged. Just today morning I heard that baby has become 6 kgs, doing well. So these kind of stories, we are happy as neonatologists, we doctors, we are very happy to listen these kind of stories. So that's what I told. Nowadays 20 less than 27 was the viable, more than 27 is the viable. Nowadays we are happy to save babies from 24 weeks.
24 weeks. So there's that much of advancement, right? Okay. What has been a very memorable NICU experience for you?
Okay, I don't remember anything as such.
Anything that's hit you hard?
Yeah, one thing, no, as such, not in NICU, I'll tell you.
Either
But
ways.
the thing is, even whenever there is a death, okay, even if it is a small child, I believe at least some of the parents are okay, understandable. Yes, in the neonatal period, they'll take it. Okay. If the child has stayed with you for 11 years, 12 years, 14 years, you have brought up the child and they expire at that age, I have seen it is intolerable pain for them that I have brought up the child for 12 to 14 years and then the child expires because of some issues. Mainly I have seen this during the dengue season at that time.
Oh,
Whenever the dengue season came, there was a huge rush which was going on in the hospitals at that time. Everybody was coming and getting admitted for the complications of the dengue mainly. Then once the bleeding starts, it used to be because of the low platelets used to drop down, and there was a huge rush going on everywhere. Platelets used to be not available. We used to run around everywhere, arrange platelets, give blood, and sometimes the bleeding never used to stop. So very less cases, but it was a very hard time, the dengue season. I have seen losing many children that time, so that is very hard. They normally, I'll tell you, is that outside public they do tell that doctors do see death day in and day out. They are not that emotionally attached to parents, to their parents, patients. So but what, as a pediatrician, I am a very emotional person. So what I have seen is, whenever we lose a child, whenever it always hits us, like we do feel bad that we tried so much but couldn't save the child. As much, I don't know how much the parents do feel, but we do as doctors, we do really feel bad for losing a child.
So do all preterm babies really develop jaundice? It's not even called jaundice, right? It is pediatric, what is it called?
Neonatal jaundice.
Neonatal jaundice. Okay. Do all preterm babies
Or
develop
it's,
that?
you can call it neonatal hyperbilirubinemia.
Okay, that is something common.
Yeah.
I will not know.
It's okay. It's jaundice. It's neonatal jaundice.
How do we identify this and what is it? Is
See,
it dangerous?
Yes. See,
Okay.
I'll tell you, every baby will have a physiological jaundice which occurs on day 3, day 4 of life. So
Okay.
if there is an inadequate feeding, baby is not sucking well or anything, if there are inadequate feeding, then the physiological jaundice, there is an exaggerated physiological jaundice at that time. Means normally we have a cutoffs for which we tell it as phototherapy cutoffs or exchange cutoff. So above which we'll have to treat the child, below which is not to treat the child. So every child will have that jaundice will be there. That is because of the baby's immature liver. Okay. So that jaundice will be there for all the babies. So in universal screening we do check on day 3 for jaundice also. This bilirubin is checked at 36 to 48 hours for all the babies, or even sometimes 72 hours for all the babies to check for jaundice. Okay. So many times it used to happen before that jaundice used to get missed. That's why this universal screening has come up. So it has been included in that. As a parent, it may be difficult for you to identify whether the child has jaundice or not. One thing, if the child is not feeding well, not sucking well, or the child is more lethargic, sleeping more, you can tell the child is sleeping more, not feeding at all, not getting up properly, then, or there is an excessive weight loss and dehydration, which can also cause jaundice to the child. So whenever day 3, day 4 baby comes, we do check for jaundice. Before getting discharged, we have one reading of the bilirubin. Before the mother and child gets discharged from the hospital, we have one reading at 36 hours. In our hospital, it's like 36 hours we do get that thing done. Blood group of the baby and the jaundice levels add together. We don't want to pick the baby again and again, together we'll get it done. At that time, we'll see whether it is in that range, treatment range. Then we'll have to start the treatment then and there. Okay. The treatment is, again, what everybody knows is that blue light what we give to the child. That is called phototherapy. So what this phototherapy works on, the principle is that what is that unconjugated bilirubin is there, which is get soluble. So after giving phototherapy, there is the structural conversion of that bilirubin and it gets easily passed out through your stools and urine. So that phototherapy or the blue light helps in that manner. One is the treatment. Then for your question whether it is dangerous or not, if the bilirubin levels are very high, okay, that we call it as exchange range. If it is not getting cured by phototherapy, the next option what we have is exchange transfusion. Means we'll have to remove the blood which has the bilirubin level, high bilirubin level, and give fresh blood to the baby.
So it's like blood transfusion.
Blood transfusion, removing the blood and giving the new blood. So it's an exchange blood transfusion what we'll have to do to the baby to prevent the complication. If not treated at all, then what can happen is it can go and damage the brain.
Okay. So it's fatal.
Yes.
Right. Yeah.
So once baby's brain is damaged, again there is developmental delay, there is palsy and everything, hearing loss, everything can happen to the baby. Yeah, jaundice is treatable, but the thing is you have to notice it early. So if it is low levels of jaundice high levels is also treatable. I'm not telling it is treatable. It is what it is, less complications are there if it is less value. If you are giving, sometimes it is borderline. Jaundice is borderline, so we give extra feeds if there is an excessive weight loss because of that and all, so we give extra amount of feeds to the baby, gets corrected, jaundice level drops down. With the phototherapy, well and good, your baby is ready to go home in the next day. So there are other causes of jaundice also. The thing is, we call it as prolonged jaundice, which occurs after 14 days of duration.
Okay.
Okay.
14 days of birth.
Birth.
Okay.
Physiological jaundice occurs in 3 to 4 days of the birth. So this prolonged jaundice is after 14 days of duration. So main two reasons for prolonged jaundice is either breast milk jaundice or breastfeeding jaundice.
Okay.
Okay. So breast milk jaundice is, there is some enzyme which is there in the breast milk only, which is not getting digested or which is not going into a circulation and everything, the bile circulation and everything. Because of that there is jaundice. Okay. That how to check for that is you can stop your breastfeeding for some time, then the jaundice level decreases and everything, then you can again go ahead, like continue your breastfeeding. So
But this does require a doctor
yes,
intervention,
yes,
right?
it does require. To get to know that only you will
Yes,
require a doctor.
I can't
and everything.
experiment it at
Correct.
home. Huh.
And one more thing is the breastfeeding jaundice, which is similar because of the inadequate breastfeeds and everything, jaundice may occur.
Okay.
So it is important to know about the different kinds of jaundice and the complications which can occur, so that it is an important cause. You have to come to the doctor and show it and take treatment as early as possible to
Okay.
prevent the complications.
Okay. Have you ever felt emotionally helpless and questioned your decision to be a pediatrician?
Yes, it may happen to anybody, I believe. So there are certain circumstances when you are helpless in saving somebody, or you do make them understand so much and then they barge into you back, some parents. So that time we'll be like, why I have become a pediatrician? It is very hard for people, for me to make them understand few things. Like better I would have taken something else. But then I'll be like, those are very less, one or two circumstances, and then by the end of the day I'll be like, this will be happening in our profession and it is there, just we should be adjusted to it. But when we see the things like violence happening against doctors, we feel that it is very bad to be in this profession, and that to be in India. Sometimes we do feel when we see all those violence, people hitting the doctors for no reason, and then taking some other anger on doctor, and then there are many circumstances where they get the patient who is already dead and then end up beating the doctor for the negligence. Only those times we feel bad. I feel to be questioned why I have taken this profession.
But the number of lives that you save
Yes.
probably keeps you going, right?
Yes.
Thank you for that service. And moving to a lighter note, I have a couple of questions for you. 4-5 questions. Just tell me whatever comes to your mind, okay?
Yes.
If babies could talk, what do you think they would come and tell you?
They would never come to a doctor, maybe.
But if they could come to you and talk and tell you about anything that's bothering them, what do you think they'll talk the most about?
They would talk about their parents, maybe. uh, about they overhyping on them, or they're like, let me have a peaceful life as a baby. Why my parents are behind me all the time?
Okay. If you had to describe your job with an emoji, which
Okay.
one would you use?
I would use it with that drop on the head, always thinking what to do in life.
Okay. If pediatricians had a superhero name, what would it be?
Maybe I can tell Flash, because we have to be very quick in understanding the children and for treating them, and we have to be in multiple places at times. So I
Okay.
believe pediatricians are very quick in doing things. I would say Flash.
Okay. Have you had a toddler that has roasted you?
Yes.
What's that been?
I would say sometimes we'll be telling the better things and all, like this you have to eat, and in front of the parents and everything. Then I have seen that children asking me, like, ನೀವು ಕೋಕೋ ಕೋಲಾ ಕುಡಿಯಲ್ವಾ, ನೀವು ಇದು ತಿನ್ನಲ್ವಾ, ಬೇಕ್ರಿ ಐಟಮ್ ತಿನ್ನಲ್ವಾ, and we be like, yes, do, we also do eat, but we tell children not to eat at that time. So it's like whenever they ask us questions back, we'll be like, it like, how good are we when we compare to them, that they already know that this fellow is only not doing, why should we do?
Okay. What has been the weirdest Google diagnosis that a parent has told you?
No, everybody has come up with saying cancer is the one thing that everybody says does this. Yeah, one, yeah, blood cancer is one. Just the had some infection. The child had some infection. Because of some minor infection, the white blood cell count had increased in the baby. Okay, then they have googled it, and the Google have showed that increase in the white blood cells is one of the thing for cancer. Can be for blood cancer also, it can be. They like, they have pestered me so much, that the child has cancer, we have to do that investigation, this and are baba, no, it is just some normal viral infection your child is having, or some bacterial infection the child is having. Because of that, the white blood cells have increased, and so be least worried. So you end up, like, in a funny manner, we get these situations at times. So they end up googling everything and coming, most of them.
Okay.
And they are ready with their questions when they come to us.
Okay.
So whatever you tell, they'll have a question in their hand.
Okay.
And you end up getting irritated most of the times, just because they already know what medications to give. When you tell some medication, we have this at home, we will give this, you have something else, you have something else. I'm like, no, you already know everything, you know better than me, you only please treat the child.
Okay. Last one. What is that parenting myth that you wish had disappeared because it drives you crazy?
One thing is, whenever the child starts crying, in neonates I am talking about, whenever the child starts crying too much, they give grey water to the child. Okay, that is one thing which has been embedded in the society, I'll tell you, because of the different kinds of brands and everything which is coming up. Gripe water is one thing, I'll tell you, it will decrease the motility of the child's intestine. Please don't give gripe water to the child as soon as the child starts crying. Okay, one more thing is that everybody keeps telling is that babies, after feeding, if they don't burp properly, baby is passing excessive gas, abdomen is distended, my baby has some problem. No, every baby while feeding takes certain amount of air inside. That's why burping is important. Every time you burp the baby, the air comes out. So few things, the one is that gripe water, giving gripe water is one thing. One more thing, must and should, I'll tell you, one doctor is already fighting about this in Tamil Nadu, is about the ORSL. Okay, which is the ready-made ORS drinks which are you are getting it in pharmacy. Those are not the WHO recommended ORS. Please don't give them to your child, or even you also don't take them. I'm telling you, WHO recommended ORS for the diarrhea is the packets what you get, the powdered packets which you have to prepare.
The electoral
Okay,
kind
electoral
of a thing.
packets what you get, those are the WHO recommended ORS. The other things, what ready-made packets are, you can see there's an apple picture, there's an orange picture which is there, all these flavored drinks they'll make you and give you in the name of ORS. Those are not the real ORS. Okay, that is one thing. Why? Because they have excess amount of sugar also in it, and when you are already having diarrhea, when you take excess of sugar, it causes asthmatic diarrhea. Your diarrhea will worsen, it will increase, and it will cause more problem to the child. If your child is not drinking the ORS at all, you are trying to feed the baby ORS, you tell, fine, no problem, give tender coconut water, give buttermilk, give normal water itself, but please don't give those ready-made drinks.
Okay, that's a powerful message. Thank you. Wrapping up this wonderful conversation, doctor, what is that one message that you would like to give expectant mothers?
be stress free in life. If you take stress, then you will give stress to the child. And taking care of the child is an overall thing which has to be done from the whole family. Not only the mother should take care of the child. So make that thing sure that you have a supporting family with you who is ready to bear everything with you to take care of the child. Okay. The child's overall development will happen with the overall family, not with one single person.
Sure. Thank you so much for that wonderful conversation, Doctor. It's created, I'm sure there is a lot of information that you've provided, and I hope it helps a lot of people. Thank you for your time once again.
Thank you so much for inviting me again.
Sure.